Good morning to people in US and good evening to people in Pakistan. My name is Sadiq Naveed. I'm a child and adolescent psychiatrist based in Connecticut. I'm chair of Apna Merit, and today's webinar is gonna cover a really important topic, which is a public health epidemic in Pakistan, and that's suicide, and especially the suicide of the younger ones in Pakistan. We have very esteemed panel today, and I'm hoping that we can spend much time on the clinical discussion, question and answer sessions. Thank you for being here today. Today's session is brought to you by different collaborators. And I will just list them shortly and then we will open the session. So our collaborators are are Apna Merit. Apna stands for Association of Pakistani Descent Physicians in North America, Pakistan Psychiatric Research Center, Child and Adolescent Psychiatry Department at King Edward Medical University, Lahore, Asian Federation of Psychiatric Association, SARC Psychiatric Federation, and CAREF International Mental Health Charity. So we'll get started, but I would like to introduce Dr. Afzal Javed. He's a mentor, teacher, and mental health advocate. He is well known in psychiatry circles. He served as president of World Psychiatric Association and about, I think, 1 to 2 years ago. And he also chairs Pakistan Psychiatric Research Center. If you heard about Fountain House in Pakistan, he's the brain behind Fountain House in Pakistan. We really appreciate for what he's doing for mental health in Pakistan. So I'll welcome Dr. Afzal Javed to give his.
Bismillah ar-Rahman Rahim. Naveed, can you hear me?
Yes.
Thank you. Dear organizers of the seminar, participants, and respected colleagues from USA and Pakistan, we are grateful to the organization of Pakistani psychiatrists in North America for continuing with their efforts to promote psychiatry and continue imparting teaching and training to psychiatrists not only in Pakistan, but also to our fellow psychiatrists in US. Today's topic is very important as like many developed countries, developing countries are also facing a big issue of suicide. And when it comes to suicide in youth, children and adolescents, this becomes even more paramount in terms of its significance and efforts to prevent these suicides, to educate the adolescents, and to share the recent updates with the professionals. I, on my personal behalf, on behalf of Pakistan Psychiatric Research Center, that has recently launched the guidelines about suicide prevention in children and adolescents, and all the speakers who have very kindly come to this webinar, and they are very keen in terms of passing on the updated information in this particular topic. Thank you very much, Dr. Naveed Saad, and it's really a sort of a privilege to be a part and collaboration with your organization. Thank you very much.
Thank you very much, Dr. Javed. We'll start with the session, but just few housekeeping items. If you have any questions, use the QA and box. It's right at the bottom of the Zoom page in the navigation panel. Ask any questions there. We will take on questions through the mic too, but that would be more towards the end. So if you have a question, just ask through the Q&A item or icon. And I will request all the panelists, while we are doing presentation, if they can answer those questions, because I assume there would be a lot of questions along the way. if you can answer those questions, if you feel like a question needs to be better answered in live, then you can hit say answer in live mode. Yeah, it gives you an option there. Our next speaker is Dr. Hassan Nazir. He is Associate Professor of Clinical Psychiatry at Weill Cornell Medicine, New York, USA. He's Division Chief for Child and Adolescent Psychiatry, Sidra Medicine in Qatar. He is very accomplished writer, thinker, and he is the driving force along with Dr. Afzal Javed behind this webinar. Thank you very much. He's going to talk about suicide in a global perspective. So we'll start with the global perspective on suicide in youth, and then we'll come down to how does it look like in Pakistan. So Walid, can you start his presentation?
This is Dr. Hassan. I will be presenting today on a global perspective on suicide. So every year about 800,000 people, they die of suicide, and majority of them happens in low to middle income countries. The literature states that North Africa and the Middle East has the lowest suicide rates. However, we need to take this data with actually the statement with a grain of salt, because this data comes from the WHO, and WHO gets this data from different individual countries. There is no other way for WHO to identify the absolute rate of the suicides in any country. So if one country does not provide the data to the WHO, then the suicide rates in that country becomes arbitrarily very low. And if you do not provide any data at all, then you live in the best country where there are no suicides. So this slide shows the share of the countries that have reported suicide data to the World Health Organization, and as you can see, around 60% of the high income countries, they have shared the data on annual suicide rates in any given year with the World Health Organization, but only 20% of the lower middle income countries do, and no low income countries have done so since 2011. This is also a similar slide that shows that the preponderance of the suicides, they happen in the low and middle income countries, and more than 50% of the suicides, they happen before 50 years of age. However, as you can see, that the serious peak happens between 10 and 20 to 25 years of age. So this slide shows an annual death rate among young people from suicide per 100,000 people in the US. And this is the data from 1950s to 2021. And over the course of years, you can see that there's a certain pattern that's emerging, which is in 1990s, you can see that the suicide rates were going downhill. And then from 2000 to about 2006, the suicide rates reached to a plateau. And since that time, they have been increasing. And in 2018, they reached to the peak, to the highest peak ever. They decrease a little bit over the course of 2 years, and now they are increasing also. I added this slide from Qatar as a comparison in the data between Qatar and in the United States, and also to show that it's very important to send high quality data. However, before 2015, there was really no child and adolescent services in Qatar, so the quality of data was not very good, and my hope is that over the course of 5 to 10 years, we will have a better quality of data, and some pattern will start shaping up. Now, this is the suicide data among young men from 1950s to 2021. The similar slide that I showed you before, but now they're dividing it in men and women, and you can see exactly the similar pattern that in 1990s the suicide rates were down, then plateau, and then a sharp increase in almost all of the age group from 15 to 19 years of age, and then from 20 to 29 years of age. This one is a simplified version of the slide that I showed you, in which you can see that from 15 to 24, the suicide rates are slightly gradually going up. I'm sorry, it looks like that my presentation is taking a life of its own, because these are animated slides, and whenever I try to click them, they don't run, but somewhere in between my presentation, they start running on their own. So bear with me about that, please. Now this is the women's data, again from 1950s to 2021, and over here you can see a gradual decline in the suicide rates, and then after 2010 a sharp increase in almost all the young age groups, from 15 to 19 years of age and 25 to 29 years of age. The difference between this data and the men's data is that, like in the men's, the suicide rates follow the roller coaster pattern, and over here there is a downward trend, and then there is a sharp peak that is increasingly getting worse. This is a simplified version of the data in which you can see that both in the ages of 10 to 14 and 15 to 24, the suicide rates are increasingly going up. Now this slide compared two age ranges, 10 to 14 and 15 to 19, among boys and girls, and in both of these groups you can see that since 2010 there has been a sharp increase in the suicide rates. The most concerning is that the increase is much more pronounced among the ages of 10 to 14, where boys has increased 137% since 2009 and girls 179% in suicides since 2009. The increase is less marked, however it is still quite significant between the age groups of 15 to 19 among boys and girls. The other important thing to remember is that the boys used to always have higher rates of suicide than girls. However, as you can see over here, that trend is also reversing, and overall there is a consensus that girls have now reached higher suicide rates than any period previously recorded. Now the question arises that why the suicide rates are increasing among the age group of 10 to 14, and part of that answer is that about 50% of all lifetime mental health disorders they begin before age 14. Any disorder other than the neurodevelopmental disorders that start from the very early childhood, you see the prodromes happening of the eating disorders, of the substance use disorders, of the personality mood disorders, bipolar and schizophrenia, significantly important. And you can see the kids started developing prodromes from 12, 13, 14, 15 years onwards, and then going into the full-blown mental disorders. And the other data is that about 75% of the all lifetime mental illnesses they start by age 24, and of course can become a significant risk factor in the emergence of suicide. The other common reasons for the suicide are the poverty, unemployment, limited educational achievement. The academic stress is a significant and real stress. And in the high-income countries, parental divorce and alcohol consumption from a very early part of the life, they become the risk factors. Young children and adolescents, they chose different methods, and that vary with the countries and the continents. And in Africa, for example, the domestic gas poisoning is common in males and overdose in females. In Canada, the hanging in both males and females, and firearm poisoning overdose that becomes more prominent. And in Pakistan, which Dr. Nazish will talk in more detail, the hanging and poisoning are the more preferred choices. Dr. Nazish will talk more about the suicide warning signs. I put the slide over here is that the warning signs are usually universal, as well as the suicide risk factors. They change a bit culturally. However, there are certain number of stressors that are quite common in the young population. As an adult, sometimes we think that there may be only one or two triggers that led a person usually to commit suicide, or at least to attempt suicide. However, when you talk with the teens who have attempted suicide, they identify a very complex system of triggers, and they do not feel that any single event can never be a sole cause. Most of the children, they have mental illnesses, and when it is not fully treated, they experience intrusive and depressive thoughts. Some children say that they have difficulty coping with social pressures such as breakups, bullying, fights with the family members. And social media, that we as an adult believe that maybe the main culprit. The adolescents believe that alone it is really a trigger. However, in the vulnerable individuals, the technology can provide a forum for trauma and further isolation that can lead to further suicides. Now, when you talk to the adolescents about the treatment, majority of them say that they want other people to know what they are going through and that they feel better and appreciate if there is someone over there to talk to them. Again, as an adult or as a physician, sometimes we worry that we do not have anything to offer. However, when you talk with adolescents, they say the completely opposite. They say that they want to get help so that they can stop feeling like dying, and coming to the emergency department just do that. It makes them feel safe by providing them with a sportive environment. It makes them less stressed out and they have fewer intrusive thoughts. They like nurses and doctors that they feel that they are being well cared for, and they also appreciate the distracting activities, simple comfort like warm blankets, nice meals that are important for them to get out of the intrusive thoughts that they are struggling with. At this time, I think I'm going above my allocated time, so I will very quickly finish the next 2 or 3 slides in about 1 minute. To prevent suicide, we can aim our interventions at the primary level, secondary level, and tertiary level. At this time in Pakistan, with this webinar and with the suicide prevention guidelines, we are trying to work at the secondary level. So there is not one single strategy that you can use to prevent suicide. The most important thing is for you to familiarize yourself with the evidence-based practices. And most importantly, you need to identify what are the risk and protective factors in your community. Again, it can be very different in a different province and a different city. Also determine the readiness in your community to implement your strategy. Talk with the champions, sponsors, look at the resistance, look where you are going to get the budget from, the willingness in the general public, whether they see it as a problem or you are the only one who is fighting through this, and the general consensus on the purpose and how to proceed, and ask for the local and outside technical assistance whenever you are ready to move towards your goal. And also consider the strategies that align culturally and religiously with the needs of your community. And during this journey, it is quite common, and you should be ready that you will find barriers. You will experience barriers, and one of that will be staff uncertainty. The people who are around you, they will not be sure about your strategy. Public misconceptions. The education is a serious issue about the mental illnesses. You will find that you don't have resources, you have staff shortage, you don't have enough money to fulfill the project that you are conducting in the school, in the community, or in other places. You will find people who may be the members of your team who lack a significant amount of training, and you will have people who have very stigmatizing attitudes towards some mental illnesses. However, if you continue pursuing your strategies, there are some standard strategies that have worked in different countries, including the low and middle income countries. And the one is the screening of the risk groups, and this is what our National Suicide Screening and Prevention Guidelines are hoping to do. Education of the parents and the primary care doctors, that's extremely important. Early intervention of the mental health disorders. As I said, that 50% of them start before 14 years of age. That is also very important, along with following up of the youth who have attempted suicide. And at a national level, you have to find ways to restrict access to the means. This has worked very well in India and in Bangladesh, and there is no reason why it will not work in Pakistan. We need to find ways for the public health awareness, some symposiums, some cultural things that can be done via the appropriate communication channels. Engaging the leadership and the opinion leaders is very important, and also to define the stereotypes and prejudicial attitudes held by the public about the mental illnesses. Working on these will be extremely important to improve the suicide rates over the next decade. Thank you so much, and apologies for taking a little bit longer than that was allocated to me. Thank you for listening.
Thank you very much. Dr. Nazir, can we also share the Pakistan recent suicide guidelines to the participants in the chat so they can also review, as some people ask for references? That's number one. Second, someone asked if the recording will be available. This will be shared on Apna YouTube channel. I'll share the link in the chat in a bit. So if you want to review it later, it is available for you to review. We are also planning for a suicide course, which will be available in future, and most likely is going to be available for free. Our next speaker is Dr. Nazish Imran. She is well known for her psychiatric services in Pakistan. She has done immense work on suicide in Pakistan. She's the chairperson and professor of Department of Child and Family Psychiatry at King Edward Medical College, Mayo Hospital, Lahore. Waleed, can you start her presentation? Thank you.
Hello everyone, I am Nazish and I will be talking to you about understanding suicide in Pakistan, cultural, clinical and social dimensions. So outline of the presentation would be that we will begin with suicide and related terminologies. We will look at the local data and Pakistan context related to suicide. We will then look at the causes, the risk and the protective factors. And towards the end, we will briefly go through the screening for the suicidal behavior. So let's begin with suicide and related terminologies. So when we talk about suicidal behaviors, it includes completed suicide, suicidal thoughts, plans, attempts, as well as deliberate self-harm. Suicide is the fatal outcome. It's the intentional act of ending one's own life, whereas suicidal ideations are thoughts about taking one's own life. Making preparations of when and how to execute the suicide, as well as considering how one's death may affect others, constitute part of suicidal ideas. Then, suicidal attempt is action taken to end one's life that did not result in death, and self harm is intentional injury without intent to die. It's important to understand that these terms are not interchangeable because each of these represents a distinct state of mind and action. And an important point to remember is that for every suicide, there are 10 to 25 suicide attempts, highlighting a critical high risk group where timely and targeted intervention can significantly reduce the overall burden of suicide. So, looking at the local data and the Pakistan context, Pakistan has an estimated population of around 240 million, with 41% of population under the age of 15. The rate of suicide and self harm in South Asia are particularly high compared to the global average. However, suicide remains a complicated and sensitive topic. A variety of social, legal, and religious factors make accurate reporting and data collection difficult in the country. And we all know that there is significant prevalent stigma and taboo related to mental illnesses as well as suicide. I would like to focus on decriminalization of suicide in Pakistan in 2022. So, until 2022, suicide was a criminal offense under Section 325 of the Pakistan Penal Code, a relic of British colonial law. So, individuals who attempted suicide were punished with imprisonment for up to 1 year, a fine, or both, further reinforcing the stigma and discouraging people from seeking help. However, the decriminalization of suicide through the Criminal Laws Amendment Bill of 2022 marked a significant shift in the state perception and treatment for mental health illnesses, albeit one which is being met with resistance from the religious and conservative political groups and fundamental political parties. However, it's important to note that with decriminalizing, evidence-based suicide prevention strategies can now be implemented more broadly. So, what does local data tells us? It's There are no official national statistics regarding suicide in Pakistan, as it lacks vital statistics registration system, and Pakistan does not report data to the World Health Organization. Being a conservative Islamic country where suicide and self-harm were criminal acts until recently, as well as socially and religiously condemned, lack of discussion about suicide and lack of data is not surprising. However, there is accumulating evidence that both the self-harm and suicide rates are on a rise in Pakistan. In the WHO Global Health Estimate of 2019, total suicides were estimated to be 19,331, and with age standardized suicide rate with 9.8, with significant differences in male and females. However, these figures are likely to be a significant gross underestimate because self-harm and suicide data, as I mentioned, which is available, is lacking in the country, and what is available is not reliable. In the first nationally representative study of psychiatric morbidity in Pakistan, this is available as preprint, and you can look it up. With Professor Razaul Rahman led that study. So there were almost 17,773 eligible participants, and among them, approximately 6,000 were in the young age group between 18 to 29 years. So the lifetime prevalence of psychiatric disorders was noted to be 37%, and the current prevalence was around 32%. Common mental health conditions included anxiety, depression, and mental illnesses were found to be more common among women, older individuals, urban residents, those with lower income, and divorced individuals. Almost 6.17% of these participants reported experiencing suicidal thoughts in the past month, and 1% had attempted suicide at some point in their life. So, although there is limited data from Pakistan, but let us look at what do we know about the suicidal behaviors among young people in the country. So, one of the study looked at analysis of suicide trends in Pakistan, and among them there were 2,295 suicides which were reported in newspaper during the 2 year study period, and 71% were under the age of 30. Then in another, which is currently unpublished, we looked at the suicidal behaviors presentation in the 6 months in the public sector hospital emergency, and among the 482 presentation, 83 were children and adolescents under the age of 18 years. And the minimum was a sort of adolescent presenting who was 12 years old. Youth, as you can see in the graph, aged 20 to 29 represented the highest proportion of suicidal behaviors in the emergency department, underscoring the need for targeted mental health interventions in this age group. Then looking at the pattern of adolescent suicide in Pakistan, among the 289 suicides in children and adolescents were reported in the selected newspaper during 2 years. An increase in the incidence of suicide in late adolescence substantiates the need for the suicide prevention intervention in this age group. And another sort of study looking at the child and adolescent psychiatry outpatients clinic, currently unpublished, showed that almost 13% of the adolescents between 10 to 18 years of age displayed suicidal behaviors. And as you can see, it included suicidal ideation, suicidal attempt, as well as deliberate self-harm. So all these, and the girls had higher suicidal behaviors and mean depression scores in this. So what we do know, looking at some of these studies, is that suicide in youth is a reality, and it is more common in the younger age group. So giving us an idea where the intervention, especially in resource constrained settings, needs to be focusing. We need to be focusing on. So let us quickly look at the risk factors. We do know that suicide is complex and has a range of risk factors. So there are some population risk factors, rapid changes in social structure, economic turmoil, especially following COVID, what we are seeing globally as well as in Pakistan, and social isolation are some of the risk factors. Then there are individual risk factors with the family history of psychiatric illness as well as suicide. Early life adversity and previous suicide attempt is one of the strongest predictor of future suicide risk. Then traits and behavior, coping strategies, impaired problem solving, high anxiety, substance abuse, cognitive deficits have all been linked with higher risk. And then there could be some triggers which may be life events, hopelessness, risk-taking behaviors, and substance abuse are there. And along with that, there are lots of environmental factors like how the media reports suicide in the country, access to means, access to mental health care are some of the environmental factors which are risk factors for suicide. Uh, we do know from some of the studies done in Pakistan, including our team, that media reporting on suicide does not often adhere to WHO guidelines, reflecting a concerning lack of responsibility in coverage which may contribute to harmful outcomes like a suicide contagion. What is again important to emphasize is that generally there is no one single cause, but rather an interplay of multiple factors which leads to increase in suicide risk. So, looking at the common risk factors for suicidal behaviors noted in literature in Pakistan, domestic conflicts, particularly interpersonal conflicts with parents as well as among the family members, comes as one of the topmost reason in majority of the researches. Then academic stress and institution-related bullying in schools and colleges is consistently being identified as a risk factor. Among them, also the comparison by the family members regarding and too much focus on academic achievements and grades does contribute. Financial reasons and poverty is another risk factor identified in Pakistan. Then gender discrimination by parents is reported in some studies as a potential triggering factor by the female adolescent, such as giving preference to son over daughter and supporting their acts. Relationship issues, failure in love, negative emotions towards the self, lack of control over their life, and disturbed interpersonal relationships and mental illnesses. Surprisingly, mental illnesses are not reported from what we sort of see in some of the studies as one of the prevalent factor. However, we do know that mental illnesses remain one of the most important underlying risk factor for suicide, and it remains underdiagnosed in Pakistan because of stigma, because of lack of access to the health services. The psychological autopsy studies done in Pakistan do show that majority of the people who die by suicide had underlying depression or any other psychiatric illnesses. There have been some studies following COVID as well as previously in which social media has been linked to suicidal behaviors in Pakistan. However, we need to understand that social media does not occur in isolation. So majority of the time there is interplay of various risk factors and social media can contribute towards the increased risk of suicidal behaviors. So, while sort of while we looked at the risk factors, there is risk factors and there are warning signs. So, risk factors suggest the increased risk, whereas when we talk about warning signs, they indicate imminent danger. So, just like in order to understand, risk factors which increase risk of heart disease may include tobacco use, obesity, high cholesterol, whereas warning signs which would indicate imminent or immediate danger of heart attack would include chest pain, shortness of breath, and nausea. So similarly, when we look at the suicide, we've already covered the risk factor, but when you look at the warning signs for suicide, if a person is wanting to be alone all the time, they are giving away important belonging, they are communicating, not being around. And in sort of youth, we are looking at this communication often in social media. If there is spike in suicidal thoughts, if someone is planning or preparing for suicide, writing a suicide note, all these are warning signs for suicide. And triggering events could be any breakup, any loss, any family stressor, any school problems, or bullying. So these are the warning signs for suicide which we need to look out for. However, while we are looking at the risk factors, it's also important to look at the protective factors. And the protective factors which have been identified in Pakistan are similar to the global protective factors, that having strong social connections, good problem solving and coping skills, religion and sense of purpose or spirituality is consistently a protective factor for suicide. Supportive family environment, if there is restricted access to legal means and access to mental health care and decreased stigma, and where there is hope for future. So these have been consistently identified as protective factors for suicide. Looking at the suicide methods, the trends and insights from Pakistan, it's not surprising that poisoning remains the most preferred method of suicide in Pakistan, giving the low cost, easy accessibility, and lack of legal restriction on the purchase of toxic pesticides, even by the young individual. So studies have come up, majority it's the insecticides and pesticide, wheat pills, rat poison, kala pathar is increasingly being used in suicidal behaviors, and household easily available materials like bleach, corrosives have been consistently noted to be one of the highest sort of method of suicide, both in youngsters as well as overall in adults. Then hanging by ceiling fans, hanging by trees is the second most common method being identified in majority of the studies, followed by firearm. And then there are other methods like drowning, jumping in front of train and from heights have also been reported, as well as self-immolation. So looking at the exploring the lived experience of adolescents presenting with self-harm and their views about suicide prevention strategies, the adolescents were sort of identified some of the predisposing factors, which were similar to what we've talked about before: interpersonal conflicts with family, emotional crisis, not being able to seek help. And they did realize that self harm is not the only option. They did talk about the perceived impact of self harm on their family members, on themselves, on their day to day life. And when they were asked about the suicide prevention strategies, they did mention that sharing it with someone, someone to talk to, does help. And they would feel more comfortable if someone asked them about these things. So the myth that talking about suicide can increase the risk, we do know that that's a myth, it's not true. Distraction techniques were considered that they should be one which helps. And then majority of the participants did wanted to talk about or involving the family in any intervention plan, because of a lot of family conflicts being there and the family being a sort of source of support, especially in a conservative, in a collective society like ours. So, from what we know, although limited data, but what we know about suicide, what are the implications for suicide prevention in Pakistan? I think one of the most important one which is coming up every time when we talk about it is reducing stigma. Having health education programs, engaging all the stakeholders, collaborating with religious scholars, all these things can help. Then improving access to care, because many at times mental illnesses remain undiagnosed and untreated. Limiting the access to means of suicide, as we have seen, the poisoning remains the number one method for suicidal behaviors in Pakistan, and many countries have reduced the rate of suicide, the burden of suicide in the country by limiting the access to means of suicide. Then we have to consider task shifting, how we can empower parents and teachers in the intervention program. So, school mental health programs, life skills training with adolescents, teachers training. These are some of the interventions which can be very, very helpful in resource constrained setting like ours. The whatever programs we come up with, they have to be culturally relevant. Use of social media can help in engaging youth in suicide prevention efforts. And national suicide prevention strategy and responsible media reporting are again some of the interventions which can help. Now, sort of quickly, we'll look at the screening for suicide. Screening is important because universal suicide screening reduces stigma and saves life. It has to be done in a sensitive and compassionate way to every patient. And we have started doing that in one of the medical unit as a pilot project, whether the patients who come up with who are admitted with medical illnesses, whether we can screen them for suicidal behavior and decrease the risk. Listening actively without passing judgment, rushing the person, interrupting, or giving advice can help. Encouraging verbal responses and demonstrating interest in their answers as well as non-verbal behavior is as important as verbal responses when we are doing screening for suicide. There are different tools available, but one very simple one is the Ask Suicide Screening question, which has 4 questions. Two focusing on the desire, two focusing on the history, and one looking at the imminency. And for on the basis of the screen, you can do further intervention. What is good news is that in last year, Professor Khalid Afzal, along with his team, translated and validated the Ask in Urdu language in Pakistan, and this is available online, and sort of this can be used very easily in very busy settings where we don't have a lot of resources to screen for suicide. So that was what I was supposed to cover regarding the webinar. So suicide is preventable, it's not inevitable. And together, by fostering awareness, compassion, and timely intervention, we can save lives and build hope. So thank you so much.
Thank you very much, Dr. Nazir Shamran. So it seems like, there's some participant who has shared some information, like Dr. Rabia Mushtaq and Alma Somro. If you want, you can send the information to apnamerit@gmail.com, and I'll share this to the speakers. I'm getting so many requests for the certificates for this session. So we're gonna give a certificate for this session, so will stay on with us. And it will be, the certificates will mention how long someone stayed with us. So Avam Ki Purjosh for Maishre, we're gonna give certificates. But let's move on to the next session, which is the fun part, which is the clinical part, which we love doing, because that brings a lot of curiosity and a connection with the patient. So we're gonna talk about suicide assessment. Dr. Salma Malik, she is Associate Professor of Psychiatry at University of Connecticut. Her primary affiliation is she's a Program Director for Child and Adolescent Psychiatry Fellowship at Institute of Living, Hartford, Connecticut. Walid, can we cue we start her presentation?
Hello, my name is Dr. Salma Malik, and I am a child and adolescent psychiatrist at the Institute of Living, which is a part of Hartford Healthcare in Connecticut, United States. I also serve as the program director for the Child and Adolescent Psychiatry Fellowship Program. It is an honor for me to be a part of this important presentation on the topic of suicide. Today, I will be discussing suicide risk assessment using the chronological assessment of suicide events, or the case approach. Following my presentation, my colleagues Dr. Awan and Dr. Khan will demonstrate some of the techniques I discuss through the use of role play based on clinical scenario. So a sound suicide assessment approach or protocol is made up of 3 components. Number 1, gathering information related to risk factors, protective factors, and warning signs of suicide, which has already been covered earlier in the presentation. Second, collecting information related to the patient's suicidal ideation, planning, behaviors, desire, and intent. And third is making a clinical formulation of risk based on these 2 databases. So if you look at the clinical and research literature, much attention has been given to the first and third tasks, which is gathering risk and protective information, warning signs, and clinical formulation. And significantly less attention has been given to the second task, which is really the detailed set of interviewing skills which are needed to effectively elicit suicidal ideation behavior, and intent. In many respects, it is the validity of the information from the second component that may yield the greatest hint of imminent suicide risk. So in our presentation today, we're going to focus on the second component of the suicide assessment. Now, there are many reasons why a patient, even with various ranges of intent, may be hesitant to openly share. And those reasons might include that the patient feels that suicide is a sign of weakness and is ashamed of acknowledging it. The patient might feel that suicide is immoral or a sin. The patient may feel really embarrassed by the discussion of suicide. The patient might feel that or does not believe that anyone can help him or her. So in order to sort of uncover the suicidal ideation, there is an equation of suicidal intent that I'm going to share with you. And real suicide intent is equal to stated intent plus reflected intent plus withheld intent. Now, this equation postulates that for any given patient, the real suicidal intent can be equal to one of the following or a combination of the intents. So let's try to understand now what are these specific components of the equation. Stated intent, as the name indicates, is what the patient directly tells the clinician about the suicidal intent. And some of the examples are, I thought I'd be gone for sure, or I thought the number of pills I took would kill me, or a statement like, I'm shocked and upset that it did not work. Next is reflected intent. Reflected intent is the quality and quantity of the patient's suicidal thoughts, desires, plans, and extent of action taken to complete the plans, which reflect how much the patient really wants to commit suicide. The extent, thoroughness, and time spent by the patient on suicidal planning may be a better reflection of the seriousness of the intent and the proximity of his desire to act on the intent than the actual stated intent. So this reflection of intent may prove to be a life-saving piece of suicide assessment puzzle. And some of the examples are, I made sure no one would find me for days. I wrote goodbye note. I took a break to get more water and then took more pills, as the first time it did not work. So to summarize, the amount of time spent thinking, planning, and practicing a suicide attempt may speak louder about the imminent risk than the patient's immediate words about the intent. So now we come to withheld intent. So withheld intent is a suicidal intent that is unconsciously or deliberately withheld from the clinician. Now, what might be some of the reasons for that? If you look at it from a psychodynamic perspective, if a patient believes that that suicide is a sign of a weakness or a sin, an unconscious defense mechanism such as denial may create the conscious belief that the patient's intent is much less than it actually is. So that could be one of the reasons. The other thing that's important to know is the patients who have serious suicidal intent, who are trying to decide how much to reveal, may share information gradually over the interview, depending on how the clinician is responding and depending on if they come to a decision during the interview that they do not want to die. At that point, they may feel safe enough to share the full truth with the clinician. So to summarize, the patient's actual intent may equal his stated intent, reflected intent, and withheld intent. And any one of these three or any combination of the three can also hold true. Now we're going to take a look at a flexible approach for uncovering suicidal ideation and intent that addresses all the concerns. It's called the case approach or chronological assessment of suicide events. It is an interviewing strategy which is designed to increase the likelihood that the patient's stated intent is accurate, that the reflected intent is comprehensive and valid, and that the amount of withheld intent is minimized or absent. So this assessment, it teaches the sophisticated art of uncovering the suicidal intent, and it comprises of 7 types of questions. There are 2 sensitivity techniques, and there are 5 validity techniques. I'm going to explain in detail about these techniques in the upcoming slides. Okay, so before we go into the techniques, let's address the question of validity. Now, you know that the answers you get depend on the questions you ask. So the problem of maximizing validity was addressed in the development of the case approach by returning to the core clinical interviewing literature, where specific validity techniques were created to uncover sensitive material. And these techniques were designed by experts in various disciplines, including psychiatry and clinical psychology and counseling. And these techniques help patients share the sensitive material in a valid manner. So let's jump into the 2 sensitivity techniques. The first one is called normalization. Normalization is the process of normalizing the topic for the patient in an unobstructed way to raise the topic of suicide. So the clinician can relate that he or she has had patients who were undergoing pains and stresses similar to those of the current patient and share that they had experienced suicidal thoughts. So an example could be that some of my patients, when feeling stressed out and depressed as you may have been feeling, tell me that they have thoughts of killing themselves. So that might open up a window for that patient to open up and talk about suicidal ideation or intent. Another related but slightly different method is to use the technique called shame attenuation. And with normalization, the patient is always asked to look at what other people have felt. With shame attenuation, the patient's own pain is used as the gateway to the topic of suicide, right? So the clinician might ask, considering all the pain you've been feeling in the past couple of weeks, I'm wondering if you have had thoughts about killing yourself. And both techniques are effective and engaging. Whichever one feels most comfortable to the interviewer can be used to uncover some of the suicidal ideation. Okay, so let's now get into the 5 other validity techniques. So they are behavioral incident, gentle assumption, denial of the specific, symptom amplification, and then catch-all question. Now, these techniques were devised to increase the likelihood of eliciting a valid response to any question that might raise sensitive material for the patient. So I also have to point out here that these techniques can also be used for other things, getting or collecting sensitive histories about sexual abuse or physical or psychological abuse or alcohol or drug use, violence, antisocial behavior. So these are good techniques to use for all potentially sensitive topics. So the first technique is behavioral incident. A patient may provide distorted information, and it could be for any number of reasons. Could be anxiety, embarrassment, protecting family secrets, So there could be a number of reasons. Now, these distortions are more likely to appear if you ask patient for opinions rather than behavioral description of events. So this is what this technique does, is that it goes into behavioral incidents. There are questions that ask for specific facts, behavior details, or trains of thoughts. These are called fact-finding behavioral incidents. So for example, you'll ask, then what happened? How many pills were left in the bottle? You would ask the patient to describe the scene as though I were watching it in a movie, so I can really picture what's happening. So you go step by step um, with description of the suicidal thoughts. Then you anchor it to time, anchor it to place, and then you summarize throughout. Help me understand what happened next. Help me understand what did you do next. Ask about the suicide note as well. So what you're trying to do is recreate that scene or sequence that behavioral incident by using the series of behavioral incidents and recreating it step by step. Now, behavioral incidents are outstanding at uncovering the hidden information, but they are time consuming, but they will give you a wealth of information. The next technique that we're going to talk about is called a gentle assumption. So gentle assumption is used when a clinician suspects that a patient may be hesitant to discuss potentially embarrassing behavior and then frames the questions accordingly in a gentle tone of voice and without judgment. So examples are, what other ways you've thought about killing yourself, or how many other times did you come close to killing yourself? For this, the gentle assumption are very powerful examples of leading questions. So you have to be careful as a clinician to, and maybe not use it with children when uncovering abuse histories, because they can potentially lead to false memories of abuse. The next technique is called denial of the specific. So this is used after the patient has denied a general question. So you ask the patient, have you thought of a specific plan to kill yourself? The patient says no. Then you actually go into 3 or more questions about specific suicidal plans. So examples, have you thought of overdosing? Have you thought of hanging yourself? Have you thought of jumping from a high place like a bridge or a building? It is important to frame each denial of the specific as a separate question and pause between each inquiry and wait for the response from the patient. The patient would either deny it or admit it. So you get that response and then you move to the next question. Let's move to the next technique, which is called symptom amplification. This technique is based on the observation that patients often minimize the frequency or amount of their behavior. So symptom amplification bypasses this minimizing mechanism. So rather than asking how often do you think about suicide, ask, in your waking hours, do you think about suicide 90% of the time, 80% of the time, or 70%? Or you can ask, do you have suicidal thoughts 7 days a week, 5 days a week, or a couple of days a week? Next, I would like to discuss it with you, the 4-step sequence for chronological assessment of suicide events. And in this, the clinician sequentially explores the 4 chronological regions. The step 1 is the clinician is asking about suicidal events in the past 2 days, so past 48 hours. And you can use some of the techniques that we have already covered. Then you go to what's called recent suicide events. Recent suicide events are past 2 months. So if it hasn't been covered, you can ask questions like, how about over the past couple of months? Have you had any thoughts about killing yourself? What ways did you think about killing yourself? Then you move to past events, and past events is 2 months back in time, right? So some of the questions you can ask is, how about in the more distant past, more than 2 months ago? Have you ever thought about killing yourself? Wait for the answer. Then next question could be, have you ever tried to kill yourself in the more distant past? How about even vague thoughts? So you've covered that region. Then the step 4 is that you need to explore about the immediate suicide events. So these are suicidal feelings, thoughts, and intent that may have arisen during the interview itself. So to cover that region, you can ask questions like, are the stressors that you were experiencing then similar to the ones you're experiencing now? And right now, what kinds of thoughts, if any, are you having about killing yourself? So the last technique that I'm going to discuss is called catch-all question. And as the name indicates, you're trying to see if anything is left in your interview. So the question could be, are there any other ways that we did not talk about that you have thought about killing yourself? So after you've done a thorough suicidal assessment, then you can put everything together in a formulation and determine risk level for suicide, which could be high, moderate, and low. And as you can see, if it's high, you might consider a hospitalization. If it's moderate, you might consider a hospitalization or develop a crisis plan and provide emergency and crisis numbers. If it's low, you might consider an outpatient referral and also give emergency and crisis numbers. So now I'm going to hand it over to my colleagues, Dr. Awan and Dr. Khan, who are going to role play by practicing these techniques that we just discussed. Dr. Awan and Dr. Khan will role play based on the following case scenario. So I'm going to pause for a minute to let you read this case. Thank you so much for your participation and listening to me. Over to you, Dr. Awan and Dr. Khan.
Thank you very much. I see a hand raised. We will take questions, after role play, and there is going to be another small presentation. Walid, can you play the role play? And this is a recording. We just wanted to do a recording so internet does not disrupt that. So I apologize for the noise and the low volume. Walid, can you play it?
So, Asim, we have been talking about your feelings, and I know it's not very easy to talk about your feelings. It takes a lot of courage to talk about how you have been feeling recently, especially with your recent exam results, the family pressure, the school struggles. It's a lot. And what you have been telling me that you have been feeling down, depressed, and even hopeless. When I've worked with a lot of kids your age, when they are going through that phase and when they're feeling very depressed, sometimes they think of killing themselves. I was wondering if you ever had those feelings or thoughts in your mind.
Yeah, I have. I've had those thoughts. It's been hard, There's just so much stress, and my parents have so many expectations. And I just feel alone a lot of the times. My dad's always in the hospital, and all my mom wants is me to become just like my dad and become a doctor, but I don't know if I can live up to that. And yeah, I've had some bad thoughts.
I'm glad that you brought that up, because I want to tell you that there is no judgment, okay? And when somebody's feeling that depressed, those thoughts, they pop up naturally. So I just want to know that because you have been so overwhelmed, how much time you are spending on these thoughts. Are these thoughts on your mind all the time, or they come and go?
I mean, honestly, it's not just once or twice. I'm having these thoughts a lot.
That sounds pretty intense, and it seems like you're carrying a lot of burden on your shoulders. Let's take it slow. If you have to recall, can you remember when was the first time you started having these thoughts?
Yeah. I mean, it started a month ago, and it coincides when I got my exam results. I didn't do that well, and from that point, these thoughts just came, and I just wish I could disappear, and it felt overwhelming.
That's pretty intense. When you say that you wish you disappear, what do you mean by that?
Just, I don't know. I mean, I just didn't want to be alive. I mean, I still remember it was, it got really bad the day after the exam.
Can you walk me through that day step by step and tell me what happened before you had those thoughts?
Yeah, I mean, I got my exam results, and I didn't get out of bed that day for a good time. I still remember vividly just feeling like gravity, just not wanting to move, and just being in bed. And I still remember it was like 12 o'clock, and I didn't leave my bedroom, and my mom walks in the room without knocking, and the first thing she says is, "Awesome, clean your room." And yeah, it's true. It was really messy. But at that time, I didn't even know if I wanted to be alive, let alone clean my room. And after that, I just remember feeling this like pang of sadness. It's one of the worst feelings I've ever felt.
You said that you did not want to be alive at that time. Did you have any thoughts? What are you going to do, or how are you going to do that?
I mean, it was a really rough day, and I felt like I was in a daze. And I was just having all kinds of negative thoughts, and I was feeling hopeless, and I felt like my future was over. How am I going to get into medical school? Things got pretty bad in the evening.
That sounds pretty rough. What did you do afterwards when you had those thoughts?
I remember at some point in the evening I went to the bathroom, and I was just looking at the mirror. It felt like I was looking at the mirror for an hour, and I did not like what I saw. And I was just contemplating if any of this is worth it. And at one point, I opened the mirror into the medicine cabinet, and I grabbed a bottle of Tylenol, and I was just staring at it.
Had you ever thought of how many pills you're going to take, or specifically what medication you're going to take?
No, to be honest, there wasn't really any sort of plan. But in that moment, I was feeling really bad, and just impulsively opened the medicine cabinet, and I was just wondering what I would do with this Tylenol bottle. And yeah, part of me wanted to just swallow the whole bottle. But I don't know what happened, but I did it, and eventually I just put the bottle back in the medicine cabinet.
That takes a lot of courage, and it tells me that even during those moments of intense pain, you still wanted to hold on, and there was part of you that wanted to cling on to life. Did you talk to anybody afterwards about that incident?
No, I didn't tell anyone.
had you written a will before you were doing that?
No, none of this was planned. Like I said, I was just feeling really low that day, and I grabbed the medicine bottle.
Have you ever thought of what's going to happen to your stuff?
No, I didn't give anything away or anything like that.
So, Asim, if you have to think about that time, what would you say? What made you stop? What made you put the bottle back?
There's a part of me that's scared of dying. What's next? What happens? And, I am a person of faith, and I believe in God, and I don't want to let God down. Like, will I go to hell if I kill myself? All these thoughts came into my mind, and I just couldn't do it.
Asim, at your age, a lot of kids who are having those painful thoughts, painful moments, they use a lot of drugs to numb those feelings. Have you ever thought of that or done that?
Are you gonna tell anyone?
No, if it's not a safety concern, everything that you're going to share with me is going to be between you and me. I would recommend that you talk to your parents about that at some point, but everything that you're going to say, if it's not a safety concern, I won't share with anybody.
Well, I've never drank alcohol, but I've never done any hard drugs. But yeah, I've done marijuana a couple times.
Was it to lessen your pain?
Yeah, I mean, like maybe like a couple days before the exam, I was feeling really stressed out, and yeah, I smoked a joint, and one of my friends does it, so he gave it to me, and I tried it once before at a party, and it relaxed me, but it's not something I usually do.
So you were still trying to use some coping mechanisms or techniques, even not the healthiest one, but you wanted to lessen your pain.
Yeah.
Any other means that you have done to hurt your life?
I don't know.
Had you thought of hanging yourself?
That sounds really painful. No, I haven't thought that.
What about poisoning yourself? Have you ever thought about that?
Poisoning myself? I wouldn't even know where to start. I don't know how to poison myself. No, I've never thought about that either.
Have you thought of using a gun?
No, we don't have a gun in our house. My dad doesn't believe in that, and I wouldn't even know where to get one.
What about jumping off a roof or maybe a bridge? Can you tell me more about that?
Yeah. So that same day, when I was contemplating taking the Tylenol, later in the evening, sometime at night actually, I think it was, I went onto our roof for some fresh air because I was just feeling really cooped up at home and I needed some fresh air. And when I was there, again, all these thoughts came into my mind, and they were just bad thoughts.
Can you tell me more about those thoughts? Were you thinking of jumping off the building?
Yeah, I mean, I was on the roof and then I kind of went towards the edge and I was looking at the stars and then I was looking at the ground, and the thought crossed my mind more than once in that moment. What would happen if I just jumped? Would it end the pain? But then, I don't know, I just chickened out again and I just turned around, went back inside,
What stopped you at that time?
You know, the same things that stopped me before. I don't know what would happen if I died. Would I go to hell? And look, as much as my parents are really difficult on me and they have such high expectations, I wouldn't want to do anything like that to disappoint them. I still want to make them proud. I just don't know how.
So, Asim, it seems like you have been thinking of ending your life quite a lot. If you have to look back, what do you think, how much time you were spending on these thoughts? If you have to put a number on it, what would you say? Like 50% of your wake time, 70% of your wake time, 90% of your wake time?
I mean, over the past month, it's been tough, and I think on most days it's been like 75%. It's been a lot, but some other days I've been able to distract myself, you know, by playing video games, and it's been a little bit less. But overall, it seems like it's been a lot.
Do you think the stressors are the same, like your education and your parents' expectations, or is there any other thought that drives these kind of thoughts and behavior?
It's pretty much just my education and feeling like a failure. And then sometimes my thoughts spiral and I wonder, well, if I don't get into medical school, then how am I going to have a job? And if I don't have a job, how am I going to find a wife? And if I don't have a wife, I'm not going to have any kids. And it just keeps going and going.
So, Asim, in the past 2 months, you said that this happened a month ago. So in the past 2 months, how many, you have any other thoughts or any other incidents where you wanted to end your life?
No, this all really just started a month ago. And before that, things weren't perfect, but I wasn't having intense thoughts to do something bad.
Let's go a little bit further back. So let's say in your lifetime, have you attempted to end your life or any other suicide attempt?
No, I've just never really had any serious suicidal thoughts, and I definitely haven't had any attempts in my life.
What about any vague thoughts?
I mean, there was a few times in my life when I was younger, like maybe after embarrassing moments, like this one time, my team was last place in the cricket tournament, and I did really bad, and for a second I thought, oh, it'd be better if I could just disappear, but that didn't last long. I remember later on that night, my dad came home and we had a nice dinner and he cheered me up, and things like that have happened a couple times, but nothing where I actually felt like I seriously wanted to hurt myself.
So Asim, right now you're sitting here and talking about your feelings and your thoughts. What do you think right now? Do you want to hurt yourself and do you want to end your life?
No, I mean, honestly, talking to you has been really good. I mean, I feel like I was carrying a boulder, and I feel a little bit lighter right now. So no, I don't want to kill myself right now.
What do you think? What makes you keep on living?
It's hard to say, but sometimes the same things that make me want to die make me want to live. I do love my parents and I want to make them proud. And I want to find a way to be successful, and maybe it's not becoming a doctor, but maybe it's something else. I just don't know how to do that right now. And
Awesome. Is there any person that you feel comfortable talking to you or sharing your feelings? It could be anybody. It could be your friend, it could be your colleague, it could be your cousin or family member.
Do you mean like sharing the feelings of having these dark thoughts?
Yes, sometimes when you're down and depressed, somebody you can share that you're feeling in this particular way so that you can express your feelings, and just the way you're talking to me and you are feeling more light just by talking.
Well, I mean, haven't thought about that, but maybe my cousin, he lives in the same city, and someone who's a few years older than me is kind of like a role model, and we're very close. And I've told him a lot of secrets in the past, and he's been really open-minded. Yeah, he's someone who I can maybe talk to.
So I really appreciate that you were able to express your feelings openly with us today, and let's make a plan so that we keep you safe. And I'm going to start with you first, and at some point I'm going to involve your parents too. With you, I have to tell you that it's very important that you open up and talk to somebody when you're in a down and dark place. Second thing I can suggest is that I'm going to give you a number for the crisis line. So if you ever had these thoughts again, it's a good idea to call that number and seek help. And if that doesn't work, or if for any other reason it's not available to you, you can always go to the nearest emergency room or hospital and seek for help. I would also encourage you to, make your communication with your parents better. It's not going to come all of a sudden, but I would encourage you to, open up and tell them how you have been feeling and what's going on in your mind. It's going to ease a lot of pressure on you too. So if you need any help with that, we are here to help you, and we can also help you with your communication, even with your parents. What do you think about the plan?
I think that would help a lot. I love my parents, but sometimes it's hard to talk about certain things, especially these dark thoughts, and I don't even know where I would start. I think they would be very surprised, and yeah, if there's a way you could help me talk to them about this.
Definitely we can do that, and we can make a plan how to work on that. Sounds good?
Thank you. Appreciate that.
Thank you so much for talking to us.
Thank you very much. And this was Dr. Fahad Awan, Dr. Iram Khan, Child and Adolescent Psychiatry Fellows from Institute of Living, Harvard. I just want every one of you to send a big round of gratitude for both of them. They were amazing. I also messaged their training director, Dr. Salman Malik, that they can have a career in probably Hollywood or Bollywood. But amazing job. This is how it is done, and it does take a lot of heart as a trainee to do this sort of work. Thank you very much. Just see that when you hear this every day, this is your job. You take piece of it at home. You see so many patients who come to you with suicide. So as a physician, it takes a toll on you on how to navigate this, how to compartmentalize this. So we have next speaker who's going to talk about this. Dr. Gila Qayyum. She is a child and adolescent psychiatrist and a child and adolescent psychiatry program director at Boston Children's. Dr. Qayyum, we have to probably, give you 10 minutes. I'm so sorry. So we can go to question and answer session. Thank you for being here today.
Sure. Thank you so much for having me. I'm going to share my screen and I'll try and be fast. I'm going to make sure I have the time correctly. Okay, can you see my screen?
Yes.
Okay, perfect. So I'll be talking about the impact of patient suicide on us as clinicians. And over the course of my career, I've been very much in acute care psychiatry, and I've had a few patients who've died by suicide. I'm going to run through a couple of case examples, but I'd ask you to keep it confidential because these are actually real cases and patients that I've actually taken care of. And so this was a case of a young adolescent female who was first seen at age 15 for suicidal ideation and self-injurious behaviors. And as I'm reading these cases, I'd like you to just think about what you've heard today in terms of risk factors. Would this be somebody you would actually be concerned about or not? The patient has suicidal ideation and self-injurious behaviors, lives with her mother, who is currently actively involved, but has a long history of anxiety, a question of PTSD from inappropriate touching by a peer. Patient is overweight and also reports significant bullying. Over the course of the next 4 years, the patient has repeated inpatient hospitalizations about 2 to 3 times a year, and a formally diagnosed with borderline personality disorder and PTSD and depression, has had multiple medication trials, and at the age of 18 also received ECT. Started community college, began to engage in some marijuana use over the weekends. Sounds like a lot of the kids that we see. Here's a 16-year-old male with one previous hospitalization who was admitted for suicidal ideation and worsening anxiety and depressive symptoms. Patient lives with both parents, and although the father was out of the country for work, the patient has had outpatient therapist, a psychiatrist with whom he has regular visits over the last year, and he takes venlafaxine and aripiprazole. The patient reports a lack of romantic relationships. His best friend has a girlfriend, and struggles with friendships as a stressor. Academically, he's doing very well, and there's no substance use. To highlight that each of these young adolescents died by suicide. And it may seem like this is just one of those very common cases that you see, but it is really difficult to predict. So we will do our best to do the risk assessment, but sometimes despite our best efforts, we can have these outcomes. And so I'll kind of talk a little generally about this, that the impact of a patient dying by suicide has significant emotional impact. And then we have this sense of unpreparedness at multiple levels, and there are things that actually complicate this as we experience it. And so there is a significant emotional impact of a patient dying by suicide. There is this sense of guilt and shame and self-doubt. You feel like you're second-guessing yourself. It might be jarring. You may feel like this happened to me, it didn't happen to my colleague, so what did I do wrong? And then there's sense of responsibility, like, was it something that I did or I didn't do or I missed that somehow contributed to this outcome? But really, it is a life-changing event. It really shakes us. And we tend to re-experience this and almost might have a sort of a traumatic re-experiencing if the death was very sudden or violent. Then there's this general sense of unpreparedness at multiple levels. Like trainees say that when they're coming into mental health care, nobody really prepares them for this kind of outcome. Like this can happen to you, this can happen to your patient, it can happen to you while you're in a training time, but it can also happen to you when you actually start practicing. Also, as supervisors, we get no guidance about, what are the sort of the legal implications? What are the administrative processes? How do you supervise trainees? What are you supposed to do? What are you supposed to say? And then programs, when we're training people in mental health treatment, don't always think about, yes, we will talk about risk assessment and helping you become proficient in conducting suicide risk assessments and safety plans, but we don't ever talk about what do you do if a patient dies by suicide? Because it's a relationship. It has a component of loss and grief and this sense of responsibility and guilt and shame and even sometimes anger at the patient and the family for acting in this way. And then we're not always very good at saying, these are the supports that are available to you, or we're going to actually sit together and talk about this as a group, and we're going to support each other. And then as a system, we rarely talk about suicide in a general sense of the institution, like we're going to make sure everybody knows what they're supposed to do, or these are the steps that need to be taken, or this is how we're going to come together to support each other. We're usually working in very high acuity, high volume environments where we have to take care of so many patients, and it's literally just next patient. Like we don't have time to stop and acknowledge and debrief about these things. So again, in general, we have this sense of unpreparedness that impacts when something like this happens because we don't know what to do and how we're supposed to prepare our trainees for this as well. Also, I talked about this. Sorry. They're mediating and complicating factors. So one of the things trainees say is that they want a credible supervisor. They want to hear and talk to and share their experience with someone who's actually had this happen to them, rather than hearing and getting support from a supervisor who hasn't had this happen to them because they don't know what it's like. So if there's a really good supervisory relationship ahead of time, it helps the trainee access Or even as a physician, if you have a good relationship with a peer or a medical director or a head of department, it's really helpful to talk to that person because you already have a good relationship. But if that person is dismissive, they sort of like, they don't really pay enough attention to it. They're overtly stoic. They have affective disconnect. They're just not present. This can really impact that supervisory experience in that relationship. Also, something to consider is that there is a societal expectation that we as mental health clinicians are going to be able to predict and prevent all suicide. And there's zero suicide policies, that one suicide is too many. And when you set the bar at no suicide, then anytime it happens to you as a clinician, it feels like a failure, like you didn't meet the mark, like you let somebody down. And then there are all these patient characteristics, like we who work with children, adolescents, it's a young patient. And not only are you considering all the life unlived, but also the potential unmet and the impact on the family and how devastating it is to lose a child by any means. But imagine having your child die by suicide, and also all the cultural and societal implications that that has for the family. And then also that sometimes there's minority status of the patient, or there might be other things going on in the family and dynamics that can sort of confers additional suicide risk to the patient and the family that you didn't appreciate initially, but in hindsight, that becomes more apparent. We have all these high-risk patients, but something to think about is this thought of shared loss. Like, how are you going to be present for someone else when you've also lost a patient? And sometimes it's really hard not to be affected and be present and support someone else. So in these initial stages, when I talked to a lot of supervisors, they said they might not have been ideally in that place where they could have given the best kind of supervision or support that they would have, because they were also reeling from this entire experience themselves. And trainees are also aware of this, that if they don't feel supported, they'll feel a difficulty in reaching out to those supervisors. But many times, trainees and other clinicians appreciate being human and seeing someone being human and authentic and transparent about their experience. And trainees also felt it was really helpful to hear from a supervisor and see that they were grieving. And this was like a parallel process. Like someone could model, it's okay. And yes, I can be a really, really good clinician or a physician, and I can still have this bad outcome, and it doesn't make me any less of a good doctor. And I will be present, and we will get through this. Some of the people who felt like their supervisor was struggling they were able to reach out to a different supervisor who was removed from the experience. And so I think this supervisor really said it well, that this will take a place in your life, and it'll have purpose, it'll have meaning, and it will feel a little, you'll never forget it. And it'll only strengthen you in the end if you let yourself think about it enough and feel enough about it. You'll be a better psychiatrist. That's how you do honor to the person who killed themselves. And I would extrapolate that to mean any clinician who's taking care of kids. So and these are based on programs supporting trainees, but I think these are important things regardless of what you do and where you are practicing, that you have to take care of other people around you and you have to prepare them. Like in the line of work that we do, this kind of thing can happen. And if something like this happens, these are the things that we're going to do. We're going to talk about this. We're going to prepare the faculty to be present and set aside time to process and debrief. How do people find out? Often it's like, it could be through the social media, it can be news, it can be a family member calling, it can be, someone just saying, hey, that patient we took care of last week, they died by suicide. But really, it's important to streamline who's giving the information, who's doing the notification, so that people are feeling supported and they're not alone or isolated when this happens, and they have somebody there. Just to debrief, and they're not left to their own devices to figure out what next, or I'm sitting with all these feelings by myself and I just don't know what to do. Also, policy and postvention protocol. Like you should have some idea and guideline of what are the supports in place, what are things that are going to happen so that um, we are able to have some in the moment guidance about what are the steps we're supposed to enact at such a time. And even if you don't have a formal policy, these are things people should have talked about beforehand and prepared. And also this messaging of, we can do our very, very best, but we have to accept that not all suicides can be prevented. And it's also important to realize that not all suicides occur because of mental illness. There's so many psychosocial factors, and one of the bigger things in children and adolescents is impulsivity, something that we really just cannot predict. And also that if we have any formal debriefing processes, if they're M&Ms, they should be done when people have been supported, they have been given the place to process this information, and then ask them to really talk about this experience. Also take a moment and pause. Acknowledge that this happened, acknowledge there's been a loss, and acknowledge that this is going to impact the people that have been involved in the care of the patient. Also provide accommodations in workload. Like, give somebody the afternoon off after something like this happens if this was their patient. Say, let's step away, get some coffee, let's talk about this. There might be people who grieve at different ways, and they might say, no, I just want to be involved and take care of my day-to-day activities because if I sit with this myself, I'm going to have a very difficult time. So again, it's better to proactively provide support so people can then accept what works for them, and don't put the burden and onus of having to ask for support on the person who's experiencing this, but that also there's people around them, as their supervisors and their directors, we step in and say, no, these are the things that are available to you, see what works for you. And then also periodic check-ins, making sure that we don't lose track of people. People grieve and process things at different times. So something else can happen later on in the year, and that would mean that now they're thinking about it, or now they're ready to talk about it. So again, periodic check-ins, particularly for rotators that rotate off service and they're going through multiple rotations. You want to make sure that you're identifying internal supports, like, these are the people within the department or within the institution that you can talk to. But then also, these are the people who've experienced this. They can help support you. And then also outside, if you need to go talk to a therapist privately, here are some of the recommendations I have. Or, let's give you some administrative support, or let's get you some training support, or we see you're on call this week. We're going to shift your call and make sure that you get some time off for yourself. And then also remembering that when we are doing good postvention, when people are feeling supported, when they know what to do, how to enact supports and other things in that moment, it's going to help suicide prevention in the future, because they will know how to approach this, they will know how to support people, and they will know how to talk about it. So they will better prepare people for the future. So thank you very much. This is my contact information. Happy to talk more about this or take questions later. And I'll put this in the chat.
Thank you very much, Dr. Qayyum. So if people on the panelists can open their videos, if they're in a situation where they can, that would be great. We also have Dr. Murad Musa Khan in the attendees. He is a leading researcher, academician for his work on suicide in Pakistan. So and around the globe too. So we really appreciate his efforts towards this public health concern. We'll go through the question and answer sessions, and I have to end this at 12:55. We'll continue to have this dialogue in future. We'll start with the first question, and let's see. Maybe, I see video open for Dr. Nazir Shimran and Dr. Gila Qayyum. So maybe one of you can answer this question. So the question is not asking directly about the idea of killing yourself can induce the thoughts of harming self in a case they don't have clear intent. Maybe formulating the question like, have you ever thought about harming yourself, is more a preventive measure. So Dr. Nazir Shimran.
Okay, thank you so much for the wonderful webinar and the question. So that's a myth that sort of asking about suicide leads to increased risk of suicide, because that was the earlier belief. But a lot of research has been done, and every time sort of the results are that asking about suicide actually leads to reduction in the risk of suicide, because many a time people feel shameful, they're not willing to disclose this information. So when you ask about it, they feel that people are able to understand what you're going through, and it's likely to reduce the risk rather than increase the risk.
Thank you. And please jump in if
I agree
anyone.
with Dr. Nazish. I agree with Dr. Nazish because during even the role play, my concern, and also during the beginning of the training, my concern about especially asking the person about specific plans, like if you have tried hanging, if you have tried using drugs, it seems like you are introducing more ideas in the brain. But as Dr. Nazish has said, that research has proven that this is being helpful exploring more. And because in the beginning a patient can just dismiss the question, not I won't say being dishonest, but it's hard for them to open up. So specifically asking these questions does help.
Yeah, I agree. And I think a lot of time in adolescence, they would answer a question in a way, can answer a question in a concrete way. So if you ask about harming self, they may think of like harming, like cutting, and they may not talk about suicide. So I have seen people saying harming, yes to harming and not to, killing themselves. So I at least tell my attendees to ask direct question, so that you can get a direct response. And because it's a significant issue, we need to address it directly. Let me see. So does diet play any role in suicide contemplation in young people? Or generally speaking, there is a growing evidence that gut is considered as second brain and plays an important role in mental health as well as overall well-being. So who wants to take this question?
I mean, I can broach the subject. I think there is emerging data about the mind-gut and the microbiome sort of like interface and interaction in depression. However, like we said, is there a direct link to suicidality? That has not yet been established. I'm not aware of any data that's looking at diet modifications. It could be sort of like indirect effects, but then there will be multifactorial. And I think if there's anything to take from today's presentation would be we're always looking for that one reason. Why did someone think about this? Why did they do this? And we have to look at how many different factors come into play into that one pivotal moment. So can diet have a role? Perhaps, maybe. Is anyone or everyone who tries to die by suicide depressed? No. So again, I think it would be rather peripheral if I were to think about it.
Thank you very much. Dr. Nazir Shimran, so there's a question, it's in context of probably Pakistan, so I'm asking you this question. And please, anyone else, if they want to jump in. I don't see open videos, so I don't know if people are at their desk or not. My brother-in-law died of suicide, even though he had a loving family and people around him. The doctor did not give any indication towards this and did not ask us to stay vigilant. What does one do in this situation?
I think that has already been answered to some extent, that usually it's not just the that sort of someone does not have a loving family, that's why they think about dying by suicide. It's generally a combination of multiple factors. So it's difficult to comment on just one factor. And usually that is it's also one of the experience that is still now healthcare professionals are often very reluctant to talk about suicide and ask about suicide. So sometimes that does happen, that because of reluctance of the healthcare professional to ask about suicide, especially in very conservative society where there's a lot of shame and guilt related to mental illnesses, people do not ask. And in that situation, you cannot do a proper assessment, and you cannot sort of perhaps communicate the need of the family to be vigilant. So that was an unfortunate sort of experience which they had. But generally, it's not just one factor that sort of perhaps that went wrong, and that's why someone died by suicide. So I think that is the point to take home, as Dr. Zila also mentioned, that usually there are multitude of factors in the background, and then there may be one triggering event which can be fatal.
Thank you very much. Dr. Afzal Javed?
Well, thank you, Sadiq Naveed. I think this is really a very important question, especially when the question asked that the doctor was unable to say anything about this. This is probably the most important thing, that number one, our professionals are not trained to deal the issue of suicide. All of them are scared because they don't feel that they are competent in terms of asking questions and then dealing with the emotions and dealing with the appropriate answers. So probably this question gives us a sort of a big lesson that we have to create awareness more among the professionals. And for that, with the help of Nazish and Asan and Waqar Azim, we are just trying to create, and I will give details at the end if you have 1 or 2 minutes. But probably this is very important point that has been raised by that. And this is something we professionals need to look at. Thank you.
Thank you very much.
Can
And
can I
go
just
ahead.
add one comment? I think just one of the important points is that during the whole medical school training, there is very limited exposure to psychiatry. So majority of the doctors, they are not, when they graduate, they are not aware of the mental illnesses to the extent where they should be. And as well as sort of there are lots of myths which even they sort of, even when they graduate, they are not addressed. I think that also contributes to them not feeling confident enough or competent enough to ask about these sensitive topics.
Thank you. I also want to introduce Dr. Professor Waqar Azim. He has been with us from the start of the session. He is one of the speakers and will give the concluding remarks. He's chair and professor of psychiatry at Sidra Medicine, Will Cornell School of Medicine. Thank you. He is my mentor, my teacher, my friend, my comrade. I have a question for you, and then I'll go to Dr. Ahsan Nazir with another question. What's the maximum time duration of medication for a psychiatric patient suffering from depression? Dr. Waqar Azim. So you're muted.
Can you repeat the question?
What is the maximum time duration of medication for a patient, psychiatric patient suffering from depression?
I think it's very hard to generalize. Every individual is very different. So when somebody is having a first episode of depression, usually it is said that if somebody has responded to medicine, that they should have at least given a trial of 9 to 12 months after they responded positively. But I think every individual should be taken very differently. I will just add one more comment. I'm looking at all the questions, and one thing which might be helpful for the participants, which I see from all over the country and from outside Pakistan. I think sometimes we focus too much on diagnosis, whether it's depression, whether it's bipolar or substance abuse. I think we should look at person as a whole and take a life in a context and think about number of things rather than just pinpointing diagnosis that is the reason for this. And if we look at a person as a whole, I think we'll have a better chance of understanding why this person is going through this, and might be we have a better chance of making more effective interventions.
Thank you very much. And Dr. Ahsan Nazir, I have a question for you. This question also showed up in the chat. Role of religion, and its impact on suicide.
So role of religion and its impact.
Yeah.
I was really hoping that you will put an easy question to me. It's a really complicated one. Again, by no means I'm an expert on religion and the suicidality. But when we were writing the guidelines, I got a chance to look into this topic relatively extensively and get a chance to talk with a couple of religious scholars from here, from Pakistan and also from Indonesia. As a Muslim, I believe that we all believe that letting ourselves go prematurely is not really the ideal way to finish our lives. However, I understand that when the time comes when the children feel that they are at the end of their rope, there are a lot of like a conflicting variables that they think through, and sometimes suicide being an impulsive act, they really don't think about religiosity and any other protective factors. So this is, I think, one of the reasons why the research is really conflicting about that. So there are a lot of like review articles on this, and I think that common finding is that the religion is protective of suicidal attempts, but it is not protective of suicidal ideations. So this is why it's very hard to figure out that if the child has a very strong religious beliefs, either from the Muslim point of view or from the Christianity point of view, whether they are gonna end their life or not. Um, Again, I think impulsivity plays a big role, but the bottom line is I think the data is really conflicting.
Thank you very much. We'll gonna conclude the session at this time. We'll go to Dr. Afzal Javed to say last minute comments, and then Dr. Waqar Azim to say the concluding remarks. Dr. Afzal Javed.
Well, thank you, Dr. Sadiq Naveed. It's really a great pleasure and privilege for listening to all the experts, and especially our younger colleagues who are now getting the expertise in many areas. I think this is really a sort of a well-planned, well-organized activity, and I'm sure that people who are not even child psychiatrists, professionals like psychiatrists, general psychiatrists, psychologists, social workers, community leaders. I mean, these educational webinars are certainly helping us a lot. As I was just mentioning earlier, that thanks for APNA for supporting Pakistan Psychiatric Research Center for the collaboration for this particular event, and with your help, which I would really ask, and especially the speakers and the panelists, that we are planning to extend our future plans for awareness for medical students. As Nazish was mentioning, this is very much high on our agenda. Awareness for GPs, awareness for religious leaders and community leaders. I think these are the groups, and of course the families and the parents. These are the groups that once they have got some working knowledge about prevention of suicide, and especially the medical students who may not be psychiatrists in future. So I think these are some of the areas where we will be working in Pakistan, and we hope that APNA will continue supporting educational activities in Pakistan. Thank you very much, and wish all the panelists a happy day. Over to you, Sadiq.
Thank you very much. And Dr. Waqar Azim for concluding remarks for today.
I will echo what Professor Afzal Javed is saying. First of all his support in having all these initiatives. Secondly, Dr. Sadiq Naveed, you as Apna Merit Chair, and all the amazing work you're doing from this forum. I know Dr. Ehsan Nazir, Dr. Nazish Imran, Dr. Hila Qayyum, and Dr. Salma Malik has played a huge part in suicide guidelines for Pakistan, which I'm hopeful will make a big difference for the families and children in most need in Pakistan. I would really like to commend our two trainees from IOL, who are the future, Dr. Fawad Awan and Dr. Iram Khan. I think you are amazing, and what you did today was unbelievable. There are two things which might be worth saying at the end. One, wonderful to see so much participation from all over the country. It's not an easy area to tackle, I think the most important thing is you need to take care of yourself first before you take care of children, families, or your patients. And secondly, other than Dr. Professor Nazish, most of us are from abroad, although have Pakistani heritage. You folks sitting in Pakistan are much more knowledgeable than us, and you can play a huge part in how we implement these suicide guidelines. So thank you so much for this opportunity and wish everyone the very best.
Thank you very much, Dr. Waqar Azim. Just last minute thanks. I have shared the WhatsApp group for the suicide is linked in the chat. So please feel free to join through the group. The recording of the session will be shared on Apna YouTube channel. I shared the link. And you will get certificates in the email when you register for this webinar. We got your email. So we'll get them to you in the next few days. And please follow up Merit on Facebook. I also shared the WhatsApp group. Feel free to join us. Thank you very much. This is just a beginning of a dialogue. This is a beginning of a collaborative effort. Thank you very much, everyone. Thank you for being here. Have a good day.